Good afternoon, everyone. Thank AIOS Scientific Committee for this opportunity. Small gatherings are always more interesting to discuss, and we can go into the details. We have all the time, looks like. So when we think of viral keratitis, it could be any virus which affects the cornea and the anterior segment, but the most common is a herpetic group of virus, of which herpes zoster is something we all have seen and know how to manage. It comes with more obvious signs. So we will be discussing about herpes simplex virus keratitis, which can present in any of these forms. It could be an active virus replication or an immune reaction to the virus particle or the virus which is in the ganglion. Now, why is it important to diagnose or suspect viral keratitis? Unfortunately, in our country, there is a blanket therapy for corneal ulcers, which includes antibacterial, antifungal, sometimes even antiviral topical. But what is important is here the role of steroids in treating viral keratitis. As we know, and in bacterial ulcer, sometimes we might add steroids. Fungal is an absolute no-no, but in viral, it is an absolute yes, and it forms a mainstay of the treatment in managing in addition to the antiviral. Also, if we do not suspect a viral keratitis, even if it's an inactive state and we operate on the patient, do a cataract surgery or any form of surgery without an antiviral cover, it can bounce back really bad to the surgeon and cause significant worsening of the corneal problem. Another differentiating feature is it is very difficult to diagnose because we do not have a very sensitive microbiological workup like in bacteria and fungus. We scrape, send to the lab, whatever comes we treat accordingly. It's not the case in viral keratitis, so it is a clinical diagnosis in most of the cases. Also, accessibility to PCR and the tests for routine OPD case or in a small practice is difficult and challenging. So when we say viral keratitis, dendrite is a very obvious sign and we all have seen and managed, but an early dendrite or a small peripheral dendrite can easily be missed. Like in this case, you have a gross overview, you find the cornea normal. When you look at this localized redness, you know that there is something there. Only when you stain, you highlight and you see the dendrite. Here I would like to describe what I call as a shadow sign. So if there is anything on the cornea, be it a small foreign body, a tiny epithelial defect, epithelial disturbance or a dendrite, when you put a light on it in an indirect illumination, a shadow of its pattern falls on the iris. There are a lot of times when in a busy OPD you're just seeing and then you see a shadow on the iris and then you defocus, come back to the cornea and you find something on the cornea. Like here you're seeing the shadow of that pattern of the dendrite on the iris, which comes out beautifully on staining. Now the next and a very common and underdiagnosed in non-cornea practicing ophthalmologist is a stromal or immune HSV keratitis. It has a very typical edema that it presents with, what we call as pot-belly edema. So the other causes of edema when we see, be it toxic endothelitis, we see an anterior stromal bulge and the thickening in the stroma, but in viral keratitis you will also see a bulge in the posterior stroma, what is called as a pot-belly edema, like we see in these cases. Now when you see a localized edema in a cornea with no infiltrate in the cornea, staining is negative, you should have a high index of suspicion for a viral keratitis. There is a very clear-cut demarcation between the stromal, the edematous part and the normal cornea. When we talk about HSV endothelitis, it presents in the form of disciform edema, a very circular, round-shaped corneal edema. Again, no stromal infiltrate, I am talking about pure endothelitis, no infiltrate in the cornea, no staining on the cornea, and clear-cut demarcation between the edematous area and the clear area. But at the same time, be very cautious in labeling as viral and adding steroids. If you see any form of some amount of infiltrate on the cornea, there is no harm in doing a microbiological workup, ruling out bacteria, fungus, and then starting the patient on steroids and antiviral. History of recurrence. So when you suspect viral keratitis, always ask the patient if there has been previous episodes. If you ask the patient, okay, has there been any redness in the past? Sometimes you'll just wave it off without, if unless you ask into the details. They very commonly say when it's hot, I sometimes get redness, but not significant, just passes away. When I'm sick, when I get fever, sometimes I get redness, but not like this. So they deny the recurrence, but you know that when they're saying there have been recurrences during illness and during febrile episodes, it could have been a viral, and this is indicating more towards the diagnosis of viral keratitis. Now, rapid melting of cornea. Unlike in cases of bacterial or fungal, where it is the late stage of the disease where the corneal thinning starts and then it perforates, melts and perforates. But in viral keratitis, it does not correlate to the extent of the lesion, but you might see a thinning and perforation very rapidly in the early stage. Now, if any patient of corneal opacity comes with a deep vessel like that, it may be in an inactive state. But as I said, if you see deep vessels like this, be alert. No harm in starting antivirals, especially in the perioperative period if you are taking the patient for a surgery. Now, this is what we call as HSV footprints, where there have been multiple recurrences and there have been scarring. So this is how it will typically look. If there has been an old bacterial keratitis or fungal keratitis, you will see one uniform large scar maybe, but here you will see irregular scarring of the cornea. At some regions it is thick, at some areas it is translucent, somewhere there is thinning. So that irregularity in the cornea along with these opacities at different levels again point towards viral keratitis. If there is any of these stromal sign with active uveitis, AC cells and keratic precipitates, it could be keratouveitis, and that is when you need, in such cases if you see AC cells, uveitis, start on steroids without antiviral cover. It will initially respond but then worsen later. Sometimes it can masquerade as a case of PUK and then turn out to be viral keratitis. Necrotizing viral is difficult to diagnose, difficult to manage, but if we suspect and start antiviral and steroids in an early stage, we can salvage the vision and the eye. So this case where I said you see an early melting and perforation in the stage of the disease. Now, when is it not viral? So if you see an epithelial defect which looks like a geographical ulcer and you're not sure whether it is viral or not, always stain with a rose bengal, and so this is not viral. But a raised margins, and when you stain with rose bengal, it will be a double staining, only the edges will take the rose bengal and the base will be stained by fluorescent. This is viral. Again, I said when it is localized edema, it points out to viral, but always rule out the other causes of localized edema, like rule out a Descemet's detachment or rule out an absent Descemet membrane, like in this case. So this edema which I said, this is not that typical pot-belly edema or a localized edema. It is a diffused edema, and this is not a viral stromal keratitis. So summarizing, always stain so that you do not miss a dendrite. Pot-belly edema, localized stromal edema suggest immune keratitis. Disciform edema, disc shape characteristic of endothelitis. Beware of deep vessels and HSV footprints, and it may warrant a perioperative antiviral cover. Necrotizing viral keratitis difficult to manage. Be nice and kind to the patient because it is a recurring problem. Please explain to them. It always happens if you do not tell them it is a recurring problem, they will go to the other doctor next door ki पिछली बार किया था ठीक हुआ वापस आ गया. So you need to tell them that this is a recurring problem, and the earliest sign of redness, photophobia, please come in so we can start the treatment as soon as possible. Thank you for your patient listening.
Thank you, Dr. Ashmita.